Mr. Johnson fell off a ladder 10 feet, landed on concrete, hit his head. When EMS arrived, he's awake, talking, says he feels fine, just a little headache. They bring him to the ED anyway. 1 hour later, Mr. Johnson is responding to questions. 2 hours later, his right pupil is blown, fixed, and dilated. 3 hours later, he's in the OR having emergency brain surgery. What happened? What did we miss? Welcome back to Neuro Authorizations Part 2. I'm Tochi, nursing student, and today we're going to be continuing where we left off. In Part 1, we covered increased ICP, increased intracranial pressure, the pressure inside the skull. Today we're talking about what causes that pressure to go up. Traumatic brain injury like Mr. Johnson falling off the ladder, stroke, and how we manage these emergencies. This is a 30-minute deep dive. We're going to follow Mr. Johnson's case throughout this video so you can see exactly how traumatic brain injury progresses and what you do as a nurse. Ready? Let's go back to the ED and see what happens next. Okay, so traumatic brain injury, TBI. This is an injury to the brain that is caused by external force. Most common causes falls, especially elderly and kids, motor vehicle crashes, spot injuries, assault, blast injuries. Blast injuries will be related to military. TBI comes up in two forms: primary injury and secondary injury. Primary injury is the immediate damage from impact. It happens at the moment of injury: skull fracture, brain contusion, and bleeding. Secondary injury is the damage that happens after the initial trauma. This is caused by swelling, inflammation, increased intracranial pressure, poor blood flow, lack of oxygen. Do you see the difference? The primary injury is at the moment of the injury: skull fracture, brain contusion, bleeding. Secondary injury is after the initial trauma, which is caused by swelling, inflammation, increased intracranial pressure, poor blood flow, and lack of oxygen. This is critical. Here's the thing: we can't undo primary injury, the damage is done, but we can prevent or minimize secondary injury. This is why the first few hours after head injury are critical. Everything we do is about preventing secondary brain injury. Let's talk about the different types of TBI. All right, there are several types of brain injuries. Let me break them down simply. Type 1: skull fractures. The skull is broken. There are four types of skull fractures. There's the linear fracture, there's the depressed fracture, there's the basilar skull fracture, and then there's the comminuted fracture. Now we'll be going deeper into the four types of structure. Lineal fracture is the four types of fracture. Lineal fracture is a simple crack in the bone, like a crack in the glass plate. It's usually no surgery is needed because it's like a crack. You're just watching the patient for complications. And then there's number two, there's depressed fraction. That means bone fragments push inward towards the brain. I don't want to use my head, but it's pushed inwards towards the brain. It can damage brain tissue, and you may need surgery to lift bone fragments from brain tissue. Basilar skull fracture is fracture at the base of the skull, like right here at the base of the skull. This is serious. Signs you will see is number one, battle sign. This is bruising behind the ears, looks like someone punched them. Raccoon eyes, that's bilateral bruising around the eyes. It's also known as periorbital osmosis. And then cerebral spinal fluid leaking from the nose. This is rhinorrhea, or the ears, otorrhea, or clear. When you see clear fluid, think cerebrospinal fluid. Clear fluid can come from the nose and from the ears. When you see something clear coming out from the nose or the ears and they've been in a sort of trauma, it is cerebrospinal fluid. If you see clear fluid draining from nose or ear after head injury, do not like try to stuff it and prevent it from coming out. No, let it drain. And then you'll tell provider immediately. Why? Because there's now a direct pathway from outside word to the brain. Like, our brain is protected. It's created in a way it's protected. There's this barrier, but now because of this injury, they're open to the outside world, and that means high infection risk, meningitis. So the fourth fracture is comminuted fracture. This is the skull is shattered into multiple pieces. It is a severe injury. It requires immediate surgery. Now, there's another type. Type 2 concussion. Number two, concussion is a type of traumatic brain injury. It's mid traumatic brain injury, like the brain is shaking inside the skull. Symptoms include brief LOC, brief loss of consciousness or not, confusion, headache, dizziness, nausea, memory problems. They can't really remember what happened. Most concussions resolve on their own, but repeated concussions can cause long-term brain damage. One concussion, fine. Two concussion, fine. Your brain will heal it. But when you start to have multiple concussion, yeah, that's not good. Type 3 of traumatic brain injury is contusion. This is a bruise on the brain when your head hits something, or when someone head hits something, the brain bounces inside the skull and get bruised. Now this is different from concussion is like the brain is shaking inside the skull, but concussion means there is a bruise on the brain. Contusion means there's a bruise on the brain. So basically, when your head hits something, the brain bounces inside the skull and it gets bruised. Now, there's coup injury. This is the bruise at the point of impact. So if you hit your head here, you're going to see a big, yeah, you see a big, I cannot remember, maybe unicorn on right there where you hit your head. That is coup injury. And then country coup injury is like, so you hit your head here. You're not going to see the injury here. You're going to see it at the back of your head. It's reverse. On the bruise is on the opposite side of the injury. So if you injure yourself here, if it's a coup injury, it will come here. You'll see the sign of injury or bruise there. But then if it's contra coup injury, you see it on the opposite side. Why opposite side? Because your head hits something and then the brain bounces forward, coup, then bounces backwards, and then hits the other side of the skull, contra coup. I hope I explained it well for you to understand. Contusions can cause bleeding and swelling, and that leads to increased intracranial pressure. Type 4 of traumatic brain injury is hematomas, and this is what happened to our case study of Mr. Johnson. Hematoma, it's a collection of blood. There are three types based on where the blood collects. Epidural hematoma, this is the blood between the skull and the dura. Dura is the outermost brain covering. It's usually like a from torn artery, often middle meningeal artery. Classic presentation in a patient will be the patient hits their head, they have brief loss of consciousness, then they wake up and seem fine, which is called the lucid interval. Then hours later, they suddenly deteriorate. This is what happened to Mr. Johnson. Why does this happen? Blood is slowly accumulating. At first, the brain is compensating. That's how cool our body is. It's compensating, but eventually, pressure gets too high and brain annihilates. On CT scan, it looks like a lens or lemon shape. Treatment, emergency surgery to drain out that blood. Now, subdural hematoma, this is the blood between the dural and the brain. Now, this is different from epidural hematoma. Remember, epidural hematoma is the blood between the skull and the dura. Subdural hematoma is the blood between the dura and the brain. It's usually from thorn vein, the bridging vein. Acute subdural, this happens within 24 to 48 hours. Chronic subdural, this develops over weeks to months, which is common in elderly who fall. Classic patient, elderly person falls, seems fine, then weeks later start acting confused, and we can't pinpoint the confusion because they fell 4 5 weeks ago, and on CT scan, it looks like a crescent or banana shape. Remember, epidural looks like a lemon shape. This one looks like a crescent or banana shape. Treatment will be surgery if large or causing symptoms. Intracerebral hematoma. This is the blood inside the brain tissue itself. I don't know if you can hear it, but it's in the name. Epidural, skull and dura, subdural, dura and brain. Then intercerebral hematoma is the blood inside the brain tissue itself. It is the most dangerous because it is directly damaging the brain, and it can cause severe increased intracranial pressure. Treatment is also surgery if it's accessible, otherwise supportive care. So, to recap, epidural is between the skull and the dural, atrial, lens shape, lucid interval. Subdural between the dura and the brain, vein, crescent shape. Intercerebral is inside the brain tissue itself, is the most dangerous. Now let's go back to Mr. Johnson and see what happened. Now, okay, let's follow Mr. Johnson case step by step. Hour 1, ED arrival. Mr. Johnson arrived by ambulance. The nurse does initial assessment, GCS 15, perfect score. That's what we want. Opens eyes simultaneously 4, E4, orientated to person, place, time, good, 5, follows command, 6. E4, V5, M6. Eyes, verbal, motor. Vital signs: BP 130/80, not too bad. HR heart rate 76, normal respiration, pupils equal round, reactive to light, parallel. Patient complains of headache, 5 out of 10. Okay, everything looks good, right? But here's what the smart ED nurse noticed. She noticed battle sign. Battle sign, bruising start appearing behind left ear. Yeah, left ear. God forbid. That's your madam. A small amount of clear fluid from left ear. Patient says is blacked out for a few seconds after the fall. Red flags. The nurse calls the provider, order CT scan of the head starts. CT results small epidural hematoma on left side about 2 centimeter. Neurosurgery is consulted. Decision admit to ICU for close monitoring. If hematoma gets bigger or patient deteriorates, surgery. Hour 2, ICU admission. Mr. Johnson is admitted to ICU, still GCS at 15, not bad. Still talking, joking with his wife. Okay, that's good. But the nurse does neuro check every hour because this is a time bomb, literally. Epidural hematomas can expand rapidly while watching for signs of increased intracranial pressure. What are we watching for? Change in level of consciousness, that's the most important. Worsening headache, pupil changes, vomiting, vital sign changes. Let's see what happened next. All right, let's talk about how you assess and monitor traumatic brain injury patients. Your first assessment is the GCS, that's the glass glow coma scale, Glasgow coma scale. This is your main tool. There are three categories. Eye opening 1 to 4 points. If the patient scores 4, that means they can open their eyes simultaneously, like that. 3, they open their eyes to voice. 2, they open their eyes to pain. 1, they don't open their eyes at all. Now we have verbal response, which has 5 points. 5, they're oriented. That means I know my name is Tochi. I know I am currently in the library, and I know today is Sunday. Confused. 4, the confused conversation. Oh, today is Saturday, 1920. A bit confused. 3, inappropriate word, blah, shwa, shwa. 2, incomprehensible sounds. 1, no verbal response. Then we have motor response, which is 6 points. 6, they obey command. Can you please squeeze my hand? Okay, thank you. 5, localizes the pain. So if I pinch them in their hand, they'll redraw, like they would reach for painful. They would do something only when you actively touch them. They like localizes to pain is so maybe when you putting the needle in, they reach for that painful stimulation to like kind of stop it. 4, they withdraw from pain. 3, flexion to pain, that's the decotate prostrate and dissociate prostrate. 3 is decotate prostrate. 2, so flexion is retracting, extension is extending. So flexion to pain 3, extension to pain 2, 1, no motor response. Now, total JCS score. If a patient, you go through this assessment, a patient get 13 to 15 as mid traumatic brain injury, 9 to 12 moderate traumatic brain injury, 3 to 8 is severe traumatic brain injury, probably in a coma. If the GCS drops by 2 or more points, red flag. Call provider immediately. Now, moving on to our second assessment, that's the pupil check. You want to check parallel. You want to make sure that pupils is equal, it's round, and it reacts to light. When light shines into your eyes dilate. Yeah, dilate. What are you looking for? Are the pupils the same size? Do they constrict when you shine lights? Yeah, do they constrict when you shine light? Sorry, your pupils constrict. So, do they constrict when you shine light? Are they round, not oval or irregular, but are they round? Now, blown pupil is fixed and dilated. This is a late sign of inanition. The brain is compressing cranial nerve 3, and it's a medical emergency. Just for your information, cranial nerve 3 is the oculomotor nerve. It's the biggest job of the nerve to control our eye movement. It controls 4 of the 6 eye muscles in each eye. I'm not going to go deeper than that. Now, back to our assessment. So for the third assessment, we have motor strength. You want to check all 4 extremity. Can they lift their hands against gravity? Can they squeeze your hand with equal strength? Can they push feet against your hands? Basically, we're going to do like, yeah, that. If one side is weaker than the other, that's a red flag. Might indicate brain injury on opposite side. Assessment for vital signs. Remember Cushing triad from part 1. That's high blood pressure, low heart rate, irregular breathing. If you see this, patient is inhaling, emergency. These assessments are done hourly initially, then every 2 to 4 hours if patient is stable. You're watching for any change that indicates worsening. Okay, back to Mr. Johnson. Hour 3 deterioration. The nurse does an hourly neuro check. Mr. Johnson is now confused, does not know what day it is. GCS has dropped from 15 to 3, is complaining headache is 9 out of 10, and is nauseous. The nurse recognizes these are signs of increase intracranial pressure. She immediately elevates head of bed to 30 degrees, calls provider, recheck vital signs. Blood pressure is now 150 over 90. Remember, before it was 130 over 80. Heart rate is now 58. It was initially 76. Cushing triad is starting. Do you remember the Cushing triad? High blood pressure, low heart rate, irregular breathing. So far, we have 2 out of 3. Provider orders stats, repeat CT scan. Result, epidural hematoma has doubled in size. Remember, it was initially 2 centimeter, now it's 4 centimeter. Significant midline shift, brain is being pushed to the side. Decision, emergency surgery now. Within 30 minutes, Mr. Johnson is in the OR. Neurosurgery performs a cre- neurosurgery performs a craniotomy. That's when they open the skull and evacuate the hematoma. They remove part of the skull bone, they drain the blood, they find the bleeding artery, and they cauterize it. So cauterize is when you burn the skin, or you burn it to basically stop bleeding, or to prevent it from becoming infected. So basically they're going to burn that. So they'll cauterize it, and then they'll replace the bone or leave it off if swelling is severe. Mr. Johnson survives because the nurse caught the deterioration early and acted fast. If she had waited 1 more hour, he might have inhabited completely and died. This is why neuro checks matter. This is why you matter. All right, now let's talk about therapeutic brain injury management. Immediate management within the first 24 hours. Your first priority, your ABCs, airway and breathing. GCS 8 or below, intubate instantly. Why? Because they can't protect their airway. They have rates of aspiration, so we need to help maintain their oxygenation. Our goal will probably be a PaO2 greater than 80, because the normal is 80 to 100, so we want it above 80. We want to maintain normal CO2. Our goal for PaCO2 is 35 to 45. PaCO2 is carbon dioxide. PaO2 is oxygen. Yes. Priority two, you want to prevent secondary brain injury. Everything we talked about in part one, you're basically going to maintain CPP, cerebral perfusion pressure, above 60 to 70. You want to control the ICP, keep it below 20. Remember, our normal level is 0 to 15, 7 to 15 in some books. You want to keep head of bed elevated 30 degrees. You want to keep head in neutral position. You want osmotic diuretic. If ICP is elevated, that's your monitor, that's your hypertonic saline. You want to avoid hypotension because it keeps brain perfused. You want to control seizure, it can increase intracranial pressure. Priority three, we want to do serial neuro assessment. Basically, your hourly GCS, your pupils, your motor strength, your vital signs. You want to watch for deterioration. Priority four, imaging, CT scan initially, then repeat as needed to monitor for expanding hematoma, increasing edema, midline shift. Priority five, you want to do surgery if indicated for this patient. We want to evacuate that hematoma. Basically, we're draining the blood. We want to decompressive craniotomy. That's basically remove the skull bone to let the brain swell. Like just give it breathing space. Because remember, our skull is rigid. It's like a rigid box. So we're going to cut that side off to let the brain swell. Ongoing management, days to weeks, depending on patients. You want to prevent complications. DVT, deep vein thrombosis. We want to prevent blood clots in legs by doing our DVT prophylaxis. Pneumonia, especially if intubated. Ventilation associated pneumonia. I've talked about it in ventilation related. Pressure ulcers, infections, nutrition. You want to start enteral feeding within 24 to 48 hours. Remember, we talked about this. Rehabilitation, we want to do physical therapy, occupational therapy, speech therapy as patient recovers. Family support, this is, you see, anytime you're dealing with patient, always know you're going to deal with family. So you wonder, this is traumatic for them too. Their loved ones that is healthy, all of a sudden they're going through this. So we need to also think of them while we're taking care of our patients. Prognosis depends on severity. Mild traumatic brain injury, that's the concussion. Concussion, it's most recover fully if they don't keep having it. Moderate therapeutic brain injury, variable outcomes 6-7. Severe traumatic brain injury, it's high risk of permanent disability or death. Early intervention improves outcome. All right, let's quickly cover stroke, another major neuro emergency. Stroke is brain attack. You know how there's myocardial infarction, which is basically another scientific fancy name for heart attack. Stroke, cerebral vascular accident is another fancy name for stroke, which is another fancy name for brain attack. Basically, blood flow to part of the brain is blocked or brain bleeds. There are two types: ischemic stroke, which is 85% of strokes, blood clots blocks an artery, brain tissue doesn't get enough oxygen, brain cells die. Causes thrombosis, clot form in brain artery, and embolus, clot travels from somewhere else like the heart and lodges in the brain. Atherosclerosis is plaque buildup, narrows arteries. Basically, let me break it down. Atherosclerosis is fat buildup in the arteries, and then when fats build up, it narrows the blood flow, like the way for the blood flow. So if the blood flow had this way, if you had a fat build up, it's going to be narrowed. That's what I mean. Treatment is TPA, which I like to call the blockbuster, clot buster. Basically, TPA, also known as the other name is Artiplas, is a tissue plasmogen activator. TPA, tissue plasmogen activator. This is a clot buster. It dissolves the clot and restores blood flow, but can only be given within 3 to 4.5 hours of symptom onset. This is why when someone have brain or stroke, they're like, you need to be fast. Face, harm, basically time. Basically, what I'm trying to say is time. So it can only be given. TPA can only be given within 3 to 4.5 hours of symptom onset. Time is brain. Every minute without blood flow, 1.9 million brain cells die. Every the brain start having necrosis for every 6 minutes it doesn't get oxygen. Now that's different without blood flow. Without blood flow, every minute without blood flow, 1.9 million brain cells die, and every 6 minutes without oxygen, it starts it starts yeah, it starts dying. That's brain cells for blood flow, brain tissue starts dying. Type 2 is the hemorrhagic stroke, which is 15% of stroke. Blood vessel in the brain ruptures, which then causes blood leaking into the brain tissue and then causes is uncontrolled hypertension, which is the most common. Ruptured aneurysm, that's the weak spot in the weak in vessel wall, and AVM, arteriovenous malfunction, abnormal tangle of vessels. Hallelujah, somebody. Mm. Treatment is different from ischemic. Remember, ischemic is the one that has the blood clots blocking blood flow for so treatment. You want to control their blood pressure, you want to reduce further bleeding, you want to do surgery if indicated by clipping the aneurysm or and removing the blood. Osmotic diuretics for increased intracranial pressure, that's the monitor. Now, critical. You cannot give TPA for hemorrhagic stroke. That would make bleeding worse. That is why CT scan is done first to determine what type of stroke before we even start treating the patient. We have to do CT scan. Immediately they come and we're like, oh, they had a stroke. We're doing CT scan to know what type of stroke before we start administrating treatment. Now, signs of stroke, remember fast. Face drooping. How can you know? You ask them to smile. If the face droops, they have it. Hand weakness, you ask them to raise both hands at the same time. When the hands start drifting, they're like they can't hold it up. Speech difficulty, ask them to repeat the statement. How are you, Mr. Johnson? Let them repeat it. Uh T is time to call 911 if they're at home or like time to do something, time for treatment. Basically, F is face drooping, A is arm weakness, S is speech difficulty, T is time. Other signs, sudden severe headache, like worst, they exclaim, oh no, this is the worst headache of their life. Sudden severe headache, that is hemorrhagic stroke. Vision changes, dizziness, loss of balance, confusion. If you see these signs, act immediately. Get CT scan, call stroke team, prepare for TPA if ischemic. Now, so what happened to Mr. Johnson? Post op, he was sedated and on ventilator for 24 hours. ICP monitored place, ICP range 10 to 18, which is normal. Day 2, sedation lifted. He woke up, he was able to follow commands. Day 3, he was extubated. That means the ventilator was taken out. He was talking, his GCS was back to 15 from 12. Day 5, he was transferred out of the ICU to the neuro floor. Day 10, he was discharged home with outpatient rehab. He had a good outcome because he got medical attention immediately. Nurse recognized early signs of deterioration. Emergency surgery happened in time because time is brain. But not all traumatic brain injury patients are this blessed. Some develop severe disability, some don't survive. This is why your assessment and your advocacy matters so much. You might be the one who catches the blown people, the dropping GCS, the cushion triad, and that makes all the difference. All right, let's recap neuro alteration part 2. One, traumatic brain injury comes in primary injury, immediate, and secondary injury after. We focus on preventing secondary injury. There's nothing we can do for primary injury. Two types of hematomas. Um, there are three types of hematomas: epidural, which is lens-shaped, lucid interval arterial; subdural, which is crescent-shaped, venous; intracerebral, which is inside the brain tissue, most dangerous. Three, assessment is everything. We needing to do hourly GCS, people's check, motor strength, vital signs. Four, GCS drop of 2 points is red flag. Call provider instantly. 5. Cushion triad: high blood pressure, low heart rate, irregular breathing equals to inhalation equals to emergency. 6. Stroke types: ischemic, which is the clot blocking blood flow, versus hemorrhagic, bleeding. Treatment is different. That is why CT scan must be done first before treatment is given. 7. Fast for stroke recognition. Time is brain. 8. Your assessment saves life. Early recognition equals to better outcome. Now, that is Neuro Part 2. If this helped you understand traumatic brain injury and stroke better, hit subscribe button. I'll be posting critical care nursing videos every week. Next week, we'll be doing Neuro Part 3. It's that big of a topic. Drop your questions below. What part of neuro nursing is still confusing? Remember, you're doing incredible. This stuff is hard, but you're learning, you're growing, and you're going to be an amazing nurse. So, next week, keep studying, stay focused, and remember, always remember, you got this. Peace out. Bye.